Hello, everyone. This is Paul Sroger from the Minneapolis Heart Institute in Minneapolis, Minnesota, and I have the pleasure of welcoming you to tonight's webinar by Cardiovascular Innovations. This is the first part in an original series that is new. This is the Imager and the Interventionalist. This is an intimate conversation with one of the leading interventional imaging specialists in the world. We're going to talk about this field and also talk about tricuspid valve disease and really take a deep dive into what it means to be an interventional imager and how that helps the interventionalists who are among us. So tonight, tonight's activity is an accredited activity, and one can get CME credit if one desires. The faculty for tonight, I'll be moderating the session, and we have the pleasure of welcoming Dr. Nadira Ahmed from Columbia University, and she is really just an exceptional interventional echocardiologist, and she's going to be talking to us about many different things that we'll go into in just a moment. We would like to thank our supporters, Abbott, Boston Scientific, and Medtronic for making this activity and possible, as well as support of CVI, all of our activities and our annual meeting, which will be this coming summer. If you'd like to claim a CME credit, you can just go online to this address or go to our website, cvinnovations.org. And this is the website for your reference. So I'd like to start off here. And as I mentioned, tonight's guest is Dr. Nadira Ahmed. Dr. Ahmed is really just established herself as a premier interventional imager with expertise on many different aspects. And especially tricuspid valve regurgitation and intraprocedural echocardiography. And we're going to be talking to her about her background, what it means to her to be an interventional echo person. And then we'll take a deep dive into a topic that's near and dear to heart, that is tricuspid valve disease. So Nadira, welcome, and thank you for being here tonight.
Thank you very much, Paul. A happy New Year to you and Happy New Year to everyone on the call. And, it's such a pleasure. And thank you so much to CVI and its board members and yourself for the invitation. It's such an honor. So thank you very much. And what a great way to start the new year, talking about the imager and the interventionist. And, my favorite topic, the tricuspid valve. So I think it's a fantastic start. So congratulations and thank you for having me.
Well, as you know, and many of my imaging partners who are out there as well, you always make us look good, and we cannot do what we do without you all as part of what we do. And so, for some of us who aren't as familiar with what an interventional imager is, just want to start off with getting to know you a little bit as well. Maybe you could start by just telling us, I know where you're from, I know where you live, I think I know what ethnicity you might be, but let's just tell us a little bit about like where you're from and how you ended up into the position you're at now.
Thank you so much, Paul. I mean, it's such a journey. I'm, like I told you before, and for those of you who know me, I'm from Singapore. Born and bred there, been raised, been around the world, as you know, studied and worked in many parts of the world. But really how I came about into the role of becoming an interventional echocardiography. It really is, the long story short of it. When I was training as a cardiology fellow back in Singapore, I fell in love with intervention and I wanted to be an interventionist. I love the catheters, doing a right and left heart and PCI. But however, there was a change of heart for multiple reasons. Could be the stress of the board exams, but
maybe it's because you actually just wanted to tell us what to do. See, because that's what the interventional echo doc does, right? Right. So it's not the interventionalists think that we're in charge, but it's actually you guys that are in charge.
I would think so. I think that's when, I was fortunate enough to be involved in one of the cases, and the first microclip case that I ever been as a cardiology fellow. And I was on the other side with my mentor and my colleague and my very good friend right now back home in Singapore, and showing me the microclip procedure, all the images as needed during a transesophageal echo, guiding the interventionist. And I knew, standing on the other side of the table, I knew then I fell in love. And that was how, I did more research into it, and attended conferences and decided to pursue this as a career, and decided to do an advanced echo fellowship. At the time, I think, the interventional echo was just born, by the one and only Dr. Rebecca Hahn, which everybody knew. And I was fortunate enough to be able to be working with her as a fellow in New York, Columbia, where I am right now. Could never have been happier and blessed to have her as a mentor, colleague, and friend, and essentially from 1 year fellowship to 2 years, and then here I am now.
I think it's really like I say, a lot of things in life. I mean, timing is just so important to everything. I mean, the timing of the launch of your career as an interventional imager at a time when interventional imaging really just was rapidly emerging must be fortuitous.
Absolutely. I think at that time when TAVR was booming, the microclip was booming at a time where, I remember still screening patients for the COAP trial, and the tricuspid has yet to even make it. So, and it was just starting at a very small surface. And so it rapidly evolved over the last few years. And, with key leaders like yourself and the imaging leaders in the world, so many of whom, too many names driving this field forward, I think it really has exploded. And I think the need for interventional imagers like us is really on the rise now. I think anywhere wants an interventional echocardiographer.
So I think we'll look back at people like, especially Becky. I mean, Becky is just, I think a lot of people owe their careers to Becky and what she has done for the field, and she will be looked at as, I don't know if I want to say grandfather, but that doesn't sound right. Grandmother, I guess, of interventional echo and procedural imaging. And what she has established as the standard, many standards about how we think about things. It must have made quite an impression upon you as a trainee.
Absolutely. I remember my first meeting with her in London, and I was completely blown away. I think too many of us still right now, we hold her in high regards. I think she's driven the field of interventional echocardiographer to a forefront, and to a world that we never knew. And I think, now is the next batch of all of us, the young ones, to drive this field further into the future. So I think the future looks great. I think, there's so much more to learn and collaborate with one another. And I'm really excited about what's coming.
Well, it's nice that you can refer to yourself as one of the young ones. That's really nice. I don't think I can really call myself young anymore, or at least I don't feel that way. So, but that's okay. But yeah, I think there's a lot to really be able to look forward to. Looking out ahead here, what kind of advice would you give to some early career people or even fellows who are considering a career in interventional imaging? What do you think are some of the things you would say now, looking back at where you've come from and been around some amazing people?
I would say, stay true to yourself, learn as much as you can, and absorb from all the people around you. And that's kind of what I did. And just, read as much as you can, but of course, besides attending the lectures, and doing the procedures or doing, helping with even the outpatient transesophageal echo, transthoracic echo as well, and really understanding what each procedure requires. And I think it's not only the procedure, Paul, I'm sure as an interventionist, we too, as imagers, do need to know the devices. We too need to understand what you do on the other side of the table so that we can connect with you as imagers and know what you want. So that on the other side of the table, we know what image you would need in order for you to perform the procedure as sleek as possible, as easy as possible, and in the best way so that we can get the best outcomes for the patient. And it's not only the procedure itself. I'm sure, Paul, you agree, it's the pre-procedural planning, for each of the patients. As we see more and more of these patients becoming more complex, the disease is multivalvular disease. So we're having multiple multidisciplinary meetings. So to any, fellows or, who's interested in this, do attend all these meetings. And we learn. I mean, I still do learn attending all these meetings because each patient is different. And, ideas come up, and that's where research opportunities as well, research questions, clinical research questions come up. And that's where, we can do clinical work, research, collaborate with other centers. So much we can do.
So how much, give us a sense of how much training and how much time it takes to really kind of master, some of these views that you do is, you did obviously dedicated time for this. A lot of fellowships don't have dedicated time. I think there's certainly a growing need at our hospital. Joao Cavalcante is putting together an imaging fellowship. Your hospital has an imaging fellowship. Others have them as well. How much time does one need to devote to this? Is it a matter of just how far you want to go, or is it a matter of daily practice? What would you say in terms of the time needed?
That's a great question. I think that is a question that everybody asks. For me personally, I knew I wanted to do this. So after cardiology fellowship, I did a year of intense echo training before pursuing my advanced training in structural intervention. And I did not 1 year, but I did 2 years of advanced interventional echo fellowship and really gather all my skills, so that I'll be comfortable enough, and still learning as I do more and more procedures. With regards to how many, I think there are, core competency statements, by a couple of interventional imagers, including Dr. Han. And, they're saying numbers, right? To do a certain number within a year, just like interventions. Of course, the more you do, the better you are. But I think really understanding it and trying to do as much as possible, I think really, really helps. And I think especially now with the current climate of COVID, I think it's very hard for fellows to get as many cases. Mm-hmm. So I think there's a role, Paul, for like simulation training. And I think that's where I think would really help our fellows in training some of these procedures.
And so do you have simulators that you guys practice on? Or, you have such volume at Columbia already. You probably don't need to do a lot of practice. You just have the volume that's here. Are there simulators that people have access to that they can do this sort of training on?
I believe so, but I think, I think there's a need for societies to push for this forward. Or, in terms of like conferences as well. I think, more as we go into this COVID pandemic, going more virtual as well. So I think there's a need for it further. Otherwise, it will be very hard, especially in other centers, not a high volume center. I think there's a need to train more of these fellows because there are many sites not only in the U.S., in the world, even in Asia, who are doing structural procedures, and as more and more of these patients, would benefit from these procedures. I think there's a need to train more imagers.
So I got to ask, so you mentioned knowing the device. So for like a MitraClip, do you know the M knob and the plus minus on the guide and all those little fancy buttons that we push and pull?
Yes, I actually had my training the TNT come to my office, and then we play around with it for a bit actually.
Yeah.
Well, and on the model and try to.
I was gonna say I have to admire that because I still have no idea what anti-flex and retroflex on the TE Pro beads. So the fact that you know M knob is pretty good.
I do my best. Of course it's very hard, but I think it's nice. It's for me, I find it nice to learn the other aspects of what you do as well. And because I've always loved it. And I think it helps me as well as an imager on the other end, manipulate the TE probe as best as I can to get the image. And that's what I love about interventional echo. I think it's about the precision to get the image as fast as possible, because I know some of the interventionists won't wait for us. But we'll do our best to get the images that we, as good as we can get,
Yeah.
So I think.
I was going to say that, it's, a crude interventionalist would think that an imager should be just like turning the TV on, and you should be able to like flip the channels and get the image you want, to the screen you want. But we know that there's so much more to it than that in terms of the manipulation and getting things in the right place. My imager, Richard Bay, I often say, dances with the probe because it's his image always seems to stay still, and I think it's because he moves with the heart, and it's pretty impressive. And he's also, just as you said, he's very good about telling me what I need to do. There's nothing like having my imager to say you should add some plus knob to the guide, and he just says it so casually as if he were just standing back there that he would just do it himself. So but that communication and that efficiency is really, really important. So, okay. Well, I think that was a really nice overview. I think that, again, interventional imaging it's so vital to what we do. And I think it's only going to get more complex because I don't think the devices are getting simpler. I think they're getting more complex in terms of how we have to think about what we want to do for our patients. And I think tonight's focus is on TR. So why don't we go ahead and get into the tricuspid space? And it's really a pleasure to have Dr. Hamid here because she has been absolutely instrumental in the Triluminate trial with me, doing the core lab work for the study. I believe you have looked at thousands of echoes for TR in the core lab. Is that right? Give us a number, Nadira. How many have you looked at for Triluminate?
Oh my God. Definitely more than 1,000.
More than 1,000. And quantitation and evaluation on all of these?
That's right. Every single one of them.
Okay.
Every single one.
So that's obviously hours and hours, thousands of hours of work at looking at the tricuspid valve. And so, I think this is really important because one of the things we want to first start talking about is how to measure TR. A lot of us, when we look at TR, we kind of gloss over it. We kind of just look at the color flow in the right atrium and kind of just get an idea of how much is there. And I think it's because, as people often refer to it, it's a bit antiquated now. It's the forgotten valve. It's not really forgotten anymore, but it's certainly, I think, still underappreciated. So I thought we'd first start by talking about quantitation. And so Nadira, do you want to take us through just some basics about how to quantitate a TR?
Thank you very much, Paul. So, like you mentioned, in the past, in terms of TR, I think everyone has been doing it visually. Just looking at, you can see the color in the right atrium, besides the size of the right atrium, giving you a sense of the TR. But really, there's better ways of doing it. The TR grading has been, as mentioned in the ASC guidelines, is to mild, moderate, and severe. But we all know that now there's higher grades of TR severity to the 5-point scale, including massive and torrential, as you can see in these images here. So, and I think, the question, is why do we really need to do this, right, Paul?
Yeah, so
Why?
it's really interesting because, when we think of clinically, severe is kind of like, well, severe means we need to do something, so there's something's threatening the patient's life or it's clinically impactful. So why do we now have something more than severe and massive and torrential? What's the purpose in that? And I think you're going to talk a little bit about that too, right?
That's right. And I think it really dates back to the initial SCOUT trial and driven by Dr. Han. And it's, was the first tri-aligned device, which is the tricuspid valve annuloplasty, which is a bicuspidization of your tricuspid valve. And from that study, 3 main points that really arise from it. One is that these patients, their baseline effective regurgitant orifice area was already severe, and there were a lot of them who was also what we deem more than severe, which is massive or torrential. That's the first point, that we found that a lot of them are more than severe. The second point being that reducing this the effective regurgitation orifice area by 1 grade really helped improve these patients. Because you have increased forward flow, and they actually do very well from the quality of life. So even the patient with torrential to massive, they do really well. Or from massive to severe, do really, really well. So, and it's really related to survival. So, which means that we really, as imagers, really need to quantitate this so that we are able to assess the TR reduction for each of these devices and see how well they do.
See, this is what I found just really almost puzzling. An ERO of 0.85. I mean, if you had an ERO of 0.85 on the mitral side, there's no way that's survivable. I mean, that is just, and that's the average. It is actually extraordinary to think about, an ERO, that big. If 0.4 is considered severe, we're twice that as a baseline. But, it was really provocative. And, Becky is obviously on the Triluminate steering committee, and we were designing Triluminate. We were talking about massive and torrential. And she really convinced us that, look, you just need to drop them by a grade and you'll improve the quality of life. And that's actually what we saw in the EFS. It was quite impressive how the KCCQ points went up by the same, whether you went from torrential to massive or massive to severe. Certainly, we want the TR to go away as much as possible, but any grade reduction is actually quite meaningful, which is really quite impressive.
Right, and this is also shown in the TriValve registry as well. So it's really, I think, important in really quantifying that, and from the SCOUT trial, we actually derived new parameters. Here is really understanding that it's a 3D structure like the mitral valve. So measuring, say, for example, your venocontractor here, just by a single view is really inadequate. And the 2 views that really for your tricuspid valve is the inflow and the 4-chamber view. So you can see on the left-hand side of the image, you're really cutting in a cross-sectional, getting a minimum and maximum diameter of your vena contracta. So of course, you will get a vena contracta wider in your RV inflow view, and it tends to be a little bit smaller in your four-chamber view. And so really orthogonal views, really is important. And so from the SCOUT trial here, we measure the average vena contracta from the orthogonal views, the inflow and four-chamber, as I mentioned. You can see on the bottom left-hand side, we measure quantitatively by 2D quantitation. What we do is measure the diastolic stroke volume across the tricuspid valve, measuring the valve area of your tricuspid annulus and in mid-diastole, and then multiply it by your pulse wave of the tricuspid VTI at the tricuspid valve. And when we subtract that from your stroke volume, your forward stroke volume, it could be your left ventricle or your right ventricle, provided there is no trace aortic regurgitation or pulmonary regurgitation. And the third method is the 3D vena contracta area. As you can see on the top right-hand side, the moving image, and really measuring the vena contracta at the leaflet tips at every single cycle of the systolic cycle, and then averaging it as well.
So there's nothing in there about jet area, jet width, anything like that I used to learn as a fellow, is there? It wasn't, or how big the color splash is or anything. There's nothing in there about that.
No. Yeah, so, those are semi-quantitative measurements. We do measure that, but it is ultimately is a multi-parametric approach. We do not just take one parameter to really define the TR severity, and not forgetting our favorite, the PISA, like in the mitral side, right, Paul? So, we do know that the assumptions of PISA.
I feel like you're making fun of. I feel like you're making fun of my medical background education. You're making fun of PISA.
No, PISA, assuming it's a flat, surface, that is a circular orifice, it's a hemispheric proximal convergence, and then really PISA radius, we're measuring it at a single time point. For measurement, but you can see the moving images here that certainly does not fit. This is the tricuspid valve, it's a salad shape. You can see the ellipsoidal nature of it on 3D. Certainly the hemispheric is not as hemispheric as you see in your mitral valve. And what really takes us is a couple of papers on it that you can see the systolic volume across your, the systolic frame of each and every cycle of the systolic frame. The tricuspid volume really differs. And you can see this diagram beautifully shown by Winkle et al. That shows what we call this temporal changes throughout the systolic cycle. And so really, the key thing about PISA is really trying to get this integrated PISA. How to overcome it? Of course, 3D PISA can help, and he has been shown to be really correlated very well with 3D vena contracta, but of course, it needs to be validated with using the different software. So how we in the core lab do it, Paul, is, and everyone is, we measure the PISA radius at every single systolic cycle and taking an average of it. And I do it for every single case for the trial trial.
Wow.
To try and get as accurate as possible your, PISA effective regurgitant orifice area or the volume, but of course, knowing that the limitations of it, that we do tend to underestimate the volume by PISA, knowing the limitations as I mentioned. And then of course, to overcome that, there are other alternative changes to the PISA by angle correction or the leaflet correction. So it is really complex. So, it can be time consuming.
Now we're going to talk a little bit about how the tricuspid valve is often not tricuspid, that you can have multiple segments, flails, degeneratives, all different things. I mean, tell me about how these methods can suffer or be better when you have multiple segments and different types of anatomy? I mean, are we pretty well validated across the different etiologies of TR?
Yeah, so I think that's where 3D really helps. So your 3D vena contracta here, like you see here, your TR is really dynamic. You can get multiple jets, as we mentioned in your multiple segments. So the 3D, you can see on the right-hand side, is a patient of ours that we did before the clip, certainly is torrential TR, measuring the vena contracta at each and every systolic cycle. And after the clip, with 2 clips in the anterior septal, you can see, this is a transthoracic that I obtained. You can see I'm measuring the 3D vena contracta area, the average of it at every systolic cycle being only 41 millimeters square, really slightly less than moderate TR with only a regurgitant volume of 26 cc's. So it really helps, especially the 3D after a clip. And before a clip in your pre-procedural planning, 3D really helps. Even during transthoracic, look at the top left-hand side image, you can see the 3D, and this is obtained on a transthoracic. The lead is really impingement of the septal leaflet and leading to really torrential TR. So I think 3D for the tricuspid really helps, just like the mitral valve, and is really beneficial both pre-procedure and also during the procedure as we go through the next section.
So is 3D vena contractor really the way to go, Nadira? I mean, just for the interventionalists, I'm so simple-minded. Like I said, I used to look at just color. I mean, tell me, is it the vena contracta, 3D vena contracta? What should I rely on?
I would certainly rely on the 3D vena contracta, but certainly there's limitations as well. With the gain, the resolution, and obviously we do need a good quality 3D volume set and acquisition of it like any other methods. But certainly it does has its role, and I think I would certainly go with 3D vena contracta. It should really correlate with your 2D quantitative method. Obviously the cutoff 75 over here. And the middle row is your PISA EROA, the cutoff of like 40 that we use for the Triluminate trial. Vena contracta width, the 7 to 13. But one key point, Paul, that I should really stress is really it's a multi-parametric approach. So don't just take one. Make sure that you do all the methods and looking at not forgetting your systolic flow reversal in your hepatic veins. And note that that is a supporting sign. You can get, hepatic systolic flow reversal in conditions like, when you have a retrograde P wave or we have junctional rhythm. So knowing all these factors as well really helps. Size of the right atrium, jet area, all these factors as well really help in assessing the TR severity. But these 3 main points really help drive the severity of the TR. And the other point, Paul, is that this is an evolving process. You've seen a lot in the literature that, there's novel algorithms. You will have, there are some suggestions, Paul, of a lower threshold than what is shown in these slides here. Of course, these are based on retrospective cohorts, database, and have been correlated with outcomes and survival. I think this is a work in progress. And I think really looking forward to, the data from the pivotal trials to help really see where we can really quantify the TR severity.
Yeah, certainly, the imaging sub-study, we're going to learn a lot. And Joao is leading that and Triluminate. And Joao is going to be our next month's guest on the Imager and Interventionalist series, and we can hear some more from him about that. But there is a lot of cross-validation we're going to be learning from here very soon. I think it's really mindful that you're right, the multi-parametric approach is really important. There's no single value we can totally rely on, that we have to put it all together. And we're going to see what's prognostic. It's really exciting. That's
right. Other novel parameters that have been suggested, measuring the vena contracta to your tricuspid valve annulus have been suggested as well, the ratio of it. Of course, these are work in progress, and I think, I'm really looking forward to see what can we come up with to help really better quantify, not only better quantify, but really identify these patients at an earlier stage, and so that they can get the treatment to the right devices. I think that's the key point.
Yeah, can't treat what we can't measure, and we got to start measuring better. Do you have any more on quantitation? Oh, fantastic.
I think just that's right. I think just pearls and pitfalls. Just remember, we do go beyond severe, massive or torrential, and it's shown to be prognostic. Be aware, 2D vena contracta, quickest. Of course, know that elliptical shape of the regurgitant orifice. 3D vena contracta is great. It can be time consuming, but I would say practice makes perfect. So I think, go ahead and practice with the transthoracic and transesophageal echo. PISA, we knew a lot of assumptions, just like a mitral, but really this can be done. It's quick and easy, and really integrated over the cardiac cycle.
Wow, that's fantastic. Wow. So right now, still a lot to do in terms of quantitation, and certainly will still rely on my imager to do the measurements for me. But at least I think I can do vena contracta with. I should be able to. I should be able to do that. I'm not sure I'm able to do much more than that, but let's move on. Let's talk some about imaging anatomy on echo. So and guide us through, like, how should we be looking at these echo images for procedural planning? Let's talk a little bit about that.
Thanks, Paul. So, here you have on the left-hand side, the surgical view. So you see that triangle of Koch. So the star there, that's where, your conduction at the membranous septum. And really for the cardiologist view, it's on the right-hand side. I mean, sometimes, when I first start learning the tricuspid valve, I get really confused as to the identification of leaflets. My suggestion is identify the main structure, adjacent structure. For example, it's the aortic valve, find where the aortic valve or the interventricular septum, and the leaflet adjacent to it. So the leaflet adjacent to the aortic valve will be your aortic leaflet, your anterior leaflet, and the leaflet adjacent to your interventricular septum will be a septal leaflet. So you orientate to the cardiologist view. So you have the septum on the, on the top, and on the bottom will be the anterior, and on the left-hand side will be the posterior. And as you mentioned, the tricuspid valve is highly variable. I mean, of course, tricuspid being 3 leaflets, it's about in 50% of patients, but we see a lot of quadricuspid 4 leaflets, with 2 posterior leaflets being the most. Some have 2 anterior, some have 2 septal leaflets, and we do see 5 and even 6 leaflets. And of course, the anterior leaflet is usually the largest.
Yeah, completely. It's beautiful.
And imaging the tricuspid valve, oh my God, it's really, really challenging. You see these leaflets here, this is a pathological specimen. And you can see here, they're really, really thin. And on top of that is really anterior. And you can have this acoustic shadowing from the fibrous crux of your interatrial septum and also the left heart. So if you have any mechanical mitral valve or mechanical aortic valve, or let alone a device across the interatrial septum like your PFO closure or your ASC occluder, it really, really, really impacts the tricuspid valve anatomy in terms of us imaging it can be really, really challenging. On top of that, look at this image, the esophagus pop really does not allow an on-force imaging. So sometimes you require lateral resolution and can be challenging as well in some of these patients.
Seems like you would spend a lot of time in the stomach to get around those left-sided structures, or deep esophageal.
Absolutely. Deep esophageal is one. The distal esophageal view is one of my favorite views, and the transgastric as well. You can really see the tricuspid valve really, really well. And so here, let me take you through a couple of the images. So here is your 4-chamber view, 0 degrees. As you can see, you have the pacing wire across really appreciate not only the right side of the heart, the RV and the RA, the leaflets well in terms of the septal and anterior. And if you retroflex a little bit, you see a little bit of that posterior leaflet. And then moving forward to bound 60 to 90 degrees, this is the key view in terms of the procedure and us really thinking about what are the possible interventions for these cases. So here is your commercial view, like in your mitral valve for the tricuspid valve. So you see on the left-hand side, the X-plane is across your center of your posterior septal. So your orthogonal view is your septal and posterior. And as you move your X-plane towards the aortic valve, that is the main adjacent structure. That would be your anterior leaflet, you can see on your orthogonal view, and the septal leaflet adjacent to it.
It's beautiful. Yeah. So antiflex, retroflex.
And this is another view. This is just the similar thing. And what in most trials, including a triluminate, what we require in terms of assessing this patient, whether they're suitable for the clip. So you want to do what we call a sweep. So on the top left-hand side, you can see your X-plane is right at the septal posterior commissures. And then you move across to your, the center of your septal posterior, all the way to the tips, really appreciating the septal posterior leaflets. And then you see on the bottom right-hand side, across to your septal anterior tips, moving towards your center anteroseptal to your mid-anteroseptal, and you can see on the bottom left-hand side, your septal anterior commissure. So doing the sweep across really gives us an idea, not only in terms of where the jet is, but ultimately the length of the septal leaf and deeming if the patient is suitable for the any transcatheter edge-to-edge devices.
Now it's a little bit difficult to see here, but that, the blue line, on the top left, it starts to the left of the screen, and that, I don't know if people can see that dotted blue line with the arrow that's moving across as you sweep across. And then the images look like they're color coded for, which ones correspond to which box. But what I think is also really impressive is, the aorta is out of the way. Because sometimes what we see in some of the imaging is that the aorta or that fibrous body is right where you're explaning off of it, and it's hard to know or hard to get the aorta out of the way. Do you have any tips or tricks for getting the aorta out of the way for these images?
Absolutely. One key tip is try and pushing in the probe a little bit deeper, and retroflexion as well, and using a small wheel to the right can certainly help. And there are some cases, I do have to admit, that this mid-esophageal view, it's very hard to really get the aorta out of the way. There will be some cases. And so that you have to rely on the other views, which is your distal esophageal view, and to try and get, the aorta out of the way to get this RV inflow view.
What about hiatal hernias? Do hiatal hernias pose a problem?
It can, pose a problem. So the distal esophageal view can be very tricky. I, try to, with the aid of my anesthesia, so before pushing the probe a little bit in, try to time it, because it can be very uncomfortable for patients. Because you're right at the junction of your esophagus and your stomach. So obviously for those hiatal hernia patients, it'd be very difficult, but, otherwise, really time it with your anesthesia to give enough sedation to the patient so that they feel comfortable as you gather these images at the distal esophageal.
Fantastic.
And so this is your intent to clip view around 140 to 180 degrees. So most of the time it's usually anteroseptal, but depending if you are, in a little bit on the higher esophagus, in your antiflex, if you retroflex, usually is your posteroseptal. And so this is, our key view, the transgastric. So this is kind of a deep transgastric here. So you can see the pacing wire across the leaflets really well. The bottom left-hand side, you can see if you take an X-plane, your orthogonal view, you can appreciate the three leaflets, your anterior, posterior, and your septal leaflets. And really, the transgastric views are the key. You can see the imaging here. And us imagers try to get your transgastric view out of the leaflets at the tips of the leaflets. So you can see here, this is it's a quadricuspid actually. So you can see on the bottom left-hand side in the still frame, you have two posterior leaflets, and really you can measure the gaps between, the anteroseptal and posteroseptal here being about 3 to 5 millimeters.
Beautiful gaps.
And so, as we mentioned, Paul, so, the tricuspid valve is highly variable. So these are the cases that I've actually seen. You can see in the top left-hand side, a patient with looks like a bicuspid. So two leaflet configuration, we deem it as type 2 based on the tricuspid valve nomenclature. So the right-hand side is a patient like the previous slide, patient with two posterior leaflets, which is a type 3B morphology. And you see on the bottom left-hand side, you can see the colored jet in between your two septal leaflets. So that's your, type 3C morphology. And the bottom right, you can see straight without the color, multiple segments, certainly two posterior and two anterior leaflets. And with your septal leaflets, so that will be 5 leaflet morphology, and that will be a type 4.
Yeah, it's quite impressive how, when you start looking at these valves in detail, I mean, just how complex they actually are. I mean, especially like the one in the bottom here, one would have, to do TEER there, multiple different coaptation planes to put back together. And I like to describe this as I've done in some of the cases, that it's like trying to grab the fingertips of these leaflets. And so if you look at that type 4 valve there, they're just fingertips of leaflets that one has to grab. And if we don't grab them right, we end up side biting. And then we're not really recreating coaptation.
Right.
Beautiful.
And so here is your deep transgastric view. This is pushing a little bit deeper into the stomach, and right and antiflex. So here you can see the Jedi, and I like the color Doppler at the bottom left-hand side, and that's where you can actually do your pulse wave and your CW, because you're literally right on the angle, perpendicular to it. So I think you can get a really nice TR pulse wave and also a CW jet from there. But here you can see the identification of the leaflets, the aortic valve, anterior and posterior on the left-hand side, septal, and the adjacent to it being the anterior leaflet.
Yeah, so we call this the Bay view when we're doing procedures, because it's, we ask for a transthoracic and Richard will just push the probe into the stomach, and it's essentially like a upside down transthoracic view. And sometimes we need this for grasping. It's fun to get. Fantastic. So we have about another 12, 13 minutes. I think we wanted to touch base a little bit on intraprocedural imaging and talk a little bit about that, because obviously we've talked about how to evaluate the tricuspid valve, but what are some of the limitations or challenges that we must think about when you're doing imaging for us in terms of these tricuspid interventions?
So here, absolutely, you can get shadowing by the guide and delivery system in the right atrium. As you can see in the image here, the esophagus path and the guide and delivery into the right atrium. In addition, some patients, they can have what we call a horizontal heart, as they lie supine on the table. So it can be challenging as well. And there are ways that we can talk about it later on. But really, essentially, 3D imaging is essential for your procedure. As I've shown in the previous slides, the multiple views, mid-esophageal, deep esophageal, shallow transgastric, and deep transgastric. Any of these views, you can really get a very nice 3D and 3D color as well, and 3D MPRs to really help guide the procedure. So here is the transgastric and your 3D procedure imaging as well. Top left-hand side, this is a tri-leaflet. You can see that the clip is oriented in the interseptal from the transgastric view, and really the bottom two images are the 3D MPRs, really help guiding the interventionist in terms of orientating the clip, and also including in terms of placement of the clip under, and also guiding in terms of leaflet capture as well. And going back to your transgastric, you can see on the right-hand side as well, beautifully placed, clip in the interseptal central. We're leaving with really mild tricuspid regurgitation on the bottom right. And as I mentioned,
so I have to ask before you go on to that. I have to ask, okay, if you know what I'm going to ask. So there's always this debate of NPR versus transgastric or 3D, and I'm always kind of harping on, well, you lose some resolution when you do NPR, and the transgastric, when you get right at the leaflet tips, boy, you can see just like millimeter resolution. You can really see beautiful bridges. So tell me, how much should I be thinking about that? How much loss of resolution is there when you have NPR versus just monoplane imaging? Well, what are we talking about here?
So, I ultimately think that your 2D image needs to be good for your 3D imaging. So if you start with the 2D imaging that is not good, do not expect your 3D imaging to be great.
Yeah.
So the main point is this 3D imaging, as you see here, that's based on very good, 2D imaging. You can see on the left-hand side that we had to go through deep esophageal because the mid-esophageal was not really great. But still here with the 3D, it can be limited. You can see the resolution of this it may be limited as well in terms of grasping, but certainly it can help you in terms of orientating the clip, and it can certainly help you on that. So I think as us imagers, really understanding the limitations of each and every modality is really key to guiding the success of the procedure.
So for like guiding and orienting and guiding like the direction, 3D NPR really fast, right? But if you really want to like be really precise about leaflet insertion and leaflet length, residual leaflet, you probably should go back to 2D, you think?
I would say I actually have done with the 3D NPR, and we can get it really well.
You're above average. So what about for the average person?
No, I think practice makes perfect. I think trying your best to get the 2D image really well, and you can try it on 3D as well. As long as the 2D image is good, you can try it on 3D and see how it is. And if your 2D image is better, go to your 2D image. There's no one method or the other, I think. I've done it on 3D NPR. It works perfectly. I can measure the leaflet length, making sure the insertion, grasping, and there are some cases where the 3D didn't help me, and so I had to go to other views and get the 2D and get the image so that I could actually make sure that the leaflets are adequately grasped, because you don't want an SLDA. So us imagers, we need to make sure that the leaflets are adequately grasped.
Okay, so no dogmatic, single-minded approach. We'll take a multifaceted approach according to tonight's presentation. I'll take it.
Okay. And so here, as mentioned, really imaging the leaflet tips throughout the cardiac cycle, and checking the leaflet length, and also, really in relation to a TR, this is your RV inflow, outflow views. And in addition, you have the new advanced technology. So this is the 3D eyes, and they are 3D NPR. So, they're new technologies now that really gives you 3D just as good as your TE. So of course, it does have its limitations, but certainly this is something that we can certainly use in the tricuspid, mitral, or left atrial appendage, and something to really to look forward to as we get used to these devices and this technology as well.
So I have to ask then, so, often the interventionalist is the one doing the ice. So what will your role be when ice, starts to take hold of more procedures in the lab? Are you going to scrub in with us?
Yes. And I would want to be manipulating the ice, actually.
There you have it. Okay, so the future interventional imagers need to be able to do ice, not just outside, not just echo outside, but also inside the body too. So that would be your expectation in terms of future skill sets. Is that fair?
That is my personal, but I'm not sure if it's for what everyone thinks, but certainly I think, this is, a field, the ice scatter, it's truly remarkable. And I think it's the way that for some patients would really benefit from this, and I think can really help, but not, certainly overtake the transesophageal echo because of certain limitations. And I think that's something that we need to learn as we learn this new technology.
Well, it's kind of like, if you look at TAVR was, has been a two operator procedure since its inception. And it's far simpler than clip imaging and clip performance. So it's not unreasonable to have somebody wholly focused on imaging and somebody wholly focused on the device working together to get the procedure done effectively. But I think it will be interesting to see how that evolves with time. So
absolutely. And not forgetting as well, we have the Echo Navigator. So here, it's literally fusion AI, and here using fusion of your echo imaging and fluoroscopy. And you can see here, this is a clip case that we perform, and, imaging and guidance with the Echo Navigator from the transeptal. Now, of course, with any new technology, it takes a while to get used to it. And once we learn, it certainly can help in terms of efficiency and communication. So certainly something to look forward to as we have more and more of these Echo Navigators in our cath lab.
So with this Echo Navigator, does this mean you talk to us less, so we don't have to talk to each other as much? Or is Becky still telling people what to do? Tell us how. It says here, improve communication efficiency. Does that mean less talking or more talking?
It's the same.
Okay, there you have it.
But certainly in terms of, where to place for a transeptal, I think, it'd be faster. I think once we learn this, I think certainly can help, in the PVL cases, certainly a lot of things that I think this is really beneficial with the Echo Navigator.
Well, it is beautiful. And I think we've been talking about fusion for more than 10, 12 years now, and still haven't quite found its place, I would say. I think there's been a lot of promise, and I think, but this is really emerging as, something really amazing from Philips. And so it'd be interesting to see where this goes. So
absolutely. And with that, thank you very much.
Well, it's been a pleasure, and I think the timing is actually perfect. I think we were thinking about going through some cases, but we spent a lot of time on some very important imaging lessons tonight already, and I think it's just been absolutely wonderful, Nadira. And I've learned a lot, and I think that there's still a lot to learn in this field. And I think for all of us who are structural interventionists out here, I'd like to say thank you to you interventional imagers for doing what you do, because we couldn't do things without you. And Like I said, you guys make us look good. So thank you.
Thank you very much. I think it's a learning process and we thoroughly enjoy, and we couldn't do our job without you too. So we certainly, I think, do need you. And I think it's a collaboration, not only interventionist imagers, our anesthesia colleagues, our cath lab nurses, all these are trained in the structural field. So it's truly a remarkable multidisciplinary, team approach towards the field, and it's continuously growing and really looking forward to the future.
Well, thank you. And I want to thank everyone for attending tonight's webinar, which I just found just absolutely fantastic. We have another one coming up next month. Look for an announcement of this will be Dr. Joao Cavalcante, who is going to share his expertise and insights into this field with us and teach us a few things as well from the imaging standpoint. And then please also mark your calendars for our meeting this coming summer in Denver. So with that, I'd like to thank Dr. Hamid again for being a wonderful guest faculty member for our first ever imager and interventionalist, and look forward to having you back. So thank you, Nadira.